Okay, recording. Okay, hi Courtney, it's Dr. Buford. We're just getting started on your left shoulder. We're looking in from the back to the front. Everything you see is magnified 30 or 40 times on the screen. Right off the bat, you can see a plastic, kind of clear plastic cannula on the left, a gray plastic cannula on the right. This area called the rotator interval is bordered by the subscap here, the MGL here, here's the labrum, and then here's the biceps tendon. And your rotator interval here is wide open because we have two cannulas in there and we can still see lots of space. And so that's a little bit bigger than normal. That goes along with our diagnosis of multidirectional instability, which we confirmed once we had you under anesthesia. I'm going to rotate up and look at the rotator cuff. No fraying or anything like that. This looks just great. So we're happy with the way the rotator cuff looks. We'll just get some of the bubbles out. Okay, so the cuff looks great. So we're going to look around towards the back of the shoulder. Posterior labrum here looks intact, a little bit thin. Here's posterior capsule. And no signs of any significant heel sac. So we're going to put the camera in the front and get to work in the back first. Okay, so recording. Okay, so now we're looking towards the back. You can see we've got a kind of a blue plastic cannula in the back here. There it is. And now we're going to go ahead and get to work on putting at least one stitch back here to stabilize the inferior glenohumeral ligament. See, as we look from here, see how wide open that is? That's what we call a drive-through sign, where you can look from the back all the way to the front easily. And it's just too loose. So we're going to take a rasp. Our rasp, and we're just going to roughen up. This is really where the posterior band of the inferior glenohumeral ligament should be, and it's really poorly defined because of the laxity or the looseness in the capsule. The anterior band would be way over here, and it's also very poorly defined. That's kind of the beginning of a fold right there, see? But it's not very distinct. So we're going to create a new inferior glenohumeral ligament for you by placing some suture anchors in. We're going to need an anchor in the front also, at least. And again, what we're doing right now is just trying to make this sticky like a piece of Velcro. I'm just kind of scuffing things up a little bit. It's actually probably enough. And so next we'll take a spinal needle. We'll check our angle to place an anchor down into the bone. Too bad there. If we can bring an anchor down, there's 6 o'clock right there. There's the front. So if we bring an anchor down right here about, that'd be about 5 o'clock if we come around the front, or 7 o'clock if we're coming around the back. So that looks pretty good right there. Hold this scope for a second. Actually, this way here. Okay. The scalpel to me. We're going to make a little nick in the skin. Take our percutaneous and now straight on through. Recording. Okay, so here you can see the drill guide coming down. You can see why we're doing this. The labrum's just a little bit loose. I'm afraid if you try to use the labrum as an anchor, it would pull loose. But we are going to place the suture anchor down right about there. Can you reach with your left hand all the way underneath? So you're not blocking. Yeah. Okay, take the drill. And once we've drilled a hole, we'll take the implant and we're going to tap that down into the bone. We'll unload the inserter and we'll see what we have there. So there's our sutures to work with. We'll pull tight to seat the anchor. That feels very tight. So now we're going to pass some sutures. So first thing we're going to reach in here, take out one of the sutures out the front. Your shoulder's so loose that we can just get it directly without having to pass off, which we sometimes have to do. Hold that in. And now we'll take a grasper in the front and turn to the right suture hook in the back. Okay, so here's our suture hook. It's a turn to the right. You can see we're going to try and come out with the tip right there, which means we're going to rotate back, go into the capsule about here. In order to do a shift, which means to tighten the capsule, we're going to go a little bit more inferior, so a little bit more this way. We go into the capsule there. We're going to rotate. See that? And then we're going to come underneath the labrum. A little bit of luck here, because your labrum's pretty thin. Okay, so we'll feed the relay. We'll show you some more in a minute. Okay, I got it. Recording. Okay, so now you can see we've passed the first limb. There it goes underneath. See how it goes underneath the labrum there and through the capsule? That looks good. We're going to do a mattress stitch, so we're going to take the second limb of the suture and bring that out the front next. There it goes. And now we're going to do the same type of stitch one more time. There's our hook. This time we want to come out about here. So we'll go into the capsule maybe a centimeter away. Something like that. Okay. Recording. Okay, so there's the first stitch, and that's in the back. So that's, again, to tighten. Already you can see how much harder it is to see below, which is exactly what we're trying to tighten this joint up. And already it's harder to see at 6 o'clock. Remember how wide open that was at the beginning of the video. So it's going to be even better once we put in some sutures down the front. But look what happens. Just by putting in that one stitch in the posterior band, we can already see exactly where the anterior band needs to go, because that's it right there. Okay, it's just not strong enough, and it's not tight enough. There's too much space. So we're going to stop in the back. I don't think we need to do anything else back here. We're going to put in some anchors in the front. Pause, please. I'm going to record, so hold tight. Okay, so here we've got the guide in. We're going to drill. Now that we have a hole, we're going to go ahead and place our implant just like we showed you in the back. And that feels very solid. So now we're going to go ahead and do the same type of thing that we did in the back. We're going to take a suture out, and then we're going to take a turn to the left hook. Okay, recording. Okay, so here's our hook in the front. We're going to start, or actually we want to finish here. So we're going to rotate. We're going to go into this capsule right about here. See where we come through. As low as we can get. There's really not a whole lot of labrum here. So we'll feed that. Okay. Recording. Okay, so we passed the first stitch. You can see it coming through the cannula. Now we're going to pass the second. We're going to go in right about here. Show you some more in a bit. Okay, so we've tied the first mattress stitch in the front, and already I'm wondering if you have to do any more, because we've eliminated the drive-through sign. See how you can't see down 6 o'clock anymore, it's gone. I don't think there's much else to do here. We may close the rotator interval, but to do that we have to look in the back. So let's go ahead and put the scope in the back, please. Okay, so what we're doing now is we're closing the rotator interval. We're going to take a little bit of the leading edge of the subscapularis tendon. You can see our needle coming through there. And we're going to pass a PDS suture through there, which is kind of a purple absorbable stitch. Need a pincher tool. This is not a suture you can grab with a grasper because it'll break. We'll go ahead and see if we can pull this out a bit. Okay, good. Okay, 2 hands on this thing. Let's use something else. Okay, so here you can see the stitch going across, and as we pull tight, see how that tightens up a little bit more? And that's why we're doing this. It's an absorbable stitch, so ultimately it'll go away, but hopefully it'll take some stress off of the rest of the repair. Okay, so we'll finish up here and get you back to the recovery room shortly. Good luck to you now. Bye-bye.